Well, first of all, I want to welcome you all to the entire bioethics program. I've been working in this program with Annalita for probably 6 or 7 years now, if not longer. And every year I'm more amazed at the work that she has done and the efforts that she's put into this so very important subject. So I want to just take this time to thank her, not only for having me present my work, but for doing this for you as students. It's so very important. Many times we get wrapped up in the mundane daily processes of learning and of living, and we really can't put as much attention to the ethics behind this and the values that we all put on all of our work and the work of taking care of, in my situation, in my career, taking care of patients, but taking care of populations and taking care of others is so very important. So I want to just give this shout out to Anna for putting this together and thank her. And I thank you all for participating from all over the world. I'm not a very seasoned traveler, but when I see you from all over the world, different countries, I am really in awe that you've found us here. So what we're going to do is talk about this very important topic, which has been the subject really of my entire career. I'm an obstetrician gynecologist, and I spent my entire career taking care of families, mothers, and children. And unfortunately, many of these times, babies that I delivered and mothers that became ill later in life died, and I needed to take care of them even in their very serious illness, and also when they were dying and when they died. And I thought about this for many, many years, and it's the whole concept of how can we heal when we cannot cure? And that's really the gist of what we're going to be discussing today. I call the talk "When We Cannot Cure: Thoughts on the Ultimate Challenge to the Bond of Patient with Doctor." Now, I do understand that many of you are not doctors nor studying to be doctors, but the mere fact that you're part of this program, I want you to consider when I mention the word, or when I use the word doctor or physician, what I'm really talking about is all of us in the health professions. So I'm not limiting this certainly to doctors, but I want you to realize that those of you who are studying ethics, psychology, informatics, whatever it is that's going to be helping other human beings, and that's really the role of humanism, I want you to think about the fact that that's really what we're focusing on. So don't be insulted if I talk about the physician. I'm really talking about all of us in the health professions. So to outline this, we're going to talk a little about the introduction. I'm going to set the tone of this talk. Then what are the themes and questions we're going to answer, and talk about humanism and the privilege that we all have of caring for others. I want to talk about the presence, our presence, and how important that is with our patients, and then reflect on a personal journey using my patients as a storyboard, and explaining to you anonymously about situations that I've encountered with patients and how I've dealt with those patients when cure was not possible. And then we'll have a conclusion and a discussion. Now, my career started, I'm going to start with the upper left. This is New York Medical College. The current location of New York Medical College is in Valhalla, New York. When I studied at New York Medical College in the 1960s, the late 1960s, it was in Manhattan. And From there, I went to Metropolitan Hospital, which is right here. Hopefully, you can see my laser pointer here. And that's Metropolitan Hospital, which is a wonderful city hospital in New York. And that's where I did my internship in both pediatrics and obstetrics. I then spent 2 years in the service, in the United States Public Health Service. And then I went in the upper right-hand corner to Yale New Haven Hospital in New Haven, Connecticut. And this is where I did my training in obstetrics and gynecology and in maternal fetal medicine. From there, I spent my years in practice of obstetrics on the faculty at the Yale School of Medicine, and I did this for the next 35 years. I also, in the interim, pursued a program in biomedical informatics. You can see here in the lower left-hand corner, that's the Oregon Health and Science University in Portland, Oregon. And I spent 4 years doing a hybrid course, both in person and online, in biomedical informatics with a particular interest in personalized health records. And then I left New Haven to come to New York, and I was the medical director of the labor floor at Mount Sinai Beth Israel Medical Center, which is in Lower Manhattan. And from there, became the associate dean for quality and safety and a professor in the Department of Obstetrics and Gynecology at Mount Sinai. And that represents my last institution. So that's just a little of my background. But all during this time, my focus has been on understanding my own feelings and trying to help others' feelings when these situations arise, again, when I could not cure or save my patients. And this is obviously a very frustrating problem for us as medical and healthcare professionals. Now, my current work is really writing, and my writing is not only in printed work that I am currently working on, but online on my website called maternal.org. And I'm just telling you this because this is my current work, and it concerns my interpretation of the human dimension of healthcare, about the human experience, hope and despair, celebration and sorrow. And by using forms of expression implicit in symbolic language, poetry, verse, song and prayer, and ritual, what I'm trying to do is share age-old empathies and lessons to enhance healing in today's complex healthcare environment. I'm sure you're all entangled in the mega complex that healthcare has become. It's not the one-to-one doctor-patient experience where a patient has the same doctor for his or her entire life. In industrialized countries, certainly in non-industrialized countries, in developing countries, the concern is not only how that healthcare is delivered, but whether it can be delivered at all. But the fact is that we're dealing with large healthcare systems where all of us, not only patients, but those that are caring for patients, are in sort of a quagmire, in a swamp of what to do and how to do this efficiently and sensitively. So I'm trying to teach how we as students, you as students, I always consider myself a student, can make things better for our patient. Now, I want to set the tone with 2 poems. The first is by Liesl Mueller. Liesl Mueller was a Pulitzer Prize-winning poet. She wrote many volumes of poetry, and this comes from her collection called Alive Together. This was actually the collection of poems that she wrote that won her the Pulitzer Prize. And she wrote this poem when her husband died, and it's called In Passing. How swiftly the strained honey of afternoon light flows into darkness, and the closed bud shrugs off its special mystery in order to break into blossom, as if what exists so that it can be lost and become precious. Now, the next poem is a poem that I wrote. And I use this poem when I talk to groups of bereaved parents. I've had the honor of being able to address multiple organizations on pregnancy loss. And when I give these talks and these discussions, I always try to use this poem because for me, I wrote the poem, but it has an important meaning for children that have died. And the poem was written for a patient of mine who had 3 successive losses of her babies, pregnancy losses, in the mid-trimester, all around 20 weeks. She stopped trying to conceive after her third death, her third baby's death. And her last baby's name was Amare. So I entitled this poem Amare and sent this poem to her. Forlorn with tears and cries am I to lose you to your death, without but even a gasp or sigh, save a wisp of angel's breath, the darkest sorrow I have known. Yet your image burnt in my soul is my gift, my grace, and always will I see your face upon the simmer of placid ponds, and in the clouds where sunbeams hide and raindrops form, and I will speak kind words and write of you, and sing in sweet demur in early morning's dew, and in the crown of daffodils, which bloom amidst the storms swept across my brow, in every dream in which it seems you come to me, my love forever do I avow. This statement, though our spirits may fade and our viscera bleed, we are enabled by the agents of our humanity, empowered by ancestral songs and promise. I wrote this when I wrote my book, Parenthood Lost, which I'll just talk to you about later on. But it really reflects the nature of this discussion that we're having today, this talk today, and what I'm presenting to you, that we are agents of our own humanity. And we need to be able to treat every patient that we see, every patient that we take care of, and every patient that may not be our direct patient, but perhaps the population of patients. We have to think about the fact that we in the healthcare professions are agents, and we are trying to help the rest of our humanity. And it's extremely important to grasp this concept. The medical professions, the health professions, the ethics professions are all so divorced from the commercial that, and as I mentioned, we're being imploded by the large healthcare systems and by commercialization. But we have to think of ourselves as separate from that. We have to think of ourselves as above the commerce and above the health system complexes, but that we can be agents of our humanity when we're caring for patients, when we're writing about this, when we're teaching. And we have to be able to empower ourselves to do this. Medicine used to be called a calling. Medicine and healthcare professions were a calling, and it was above the fray of earning a living, above the fray of insurance companies. It was a calling because those that entered medicine felt that it was something that was inherent in what they wanted to do to help others. And unfortunately, this is not thought about a lot, and that's one of the impetuses for me presenting this to you today. So what are we going to talk about as we move along in this talk? We're going to talk about how can a patient-centric humanistic approach to the care of all patients promote healing when we cannot cure. And how can we heal when our patients are incurable and are suffering and then die? Why are we in the health professions? Why are we health professionals? What is our duty to teach others, to give a share? And this is a sort of a translated quote from the writings of Hippocrates, to give a share of precepts and oral instruction to pupils who have signed the covenant. This is from the Hippocratic Oath. And we're going to ask, can compassion and empathy be taught and learned? I do believe it can. And most important, what I believe is, what is our privilege of caring? We have this privilege, all of us, to know and understand is a dimension of being scientific, but to be known and understood is a dimension of caring and being cared for. George Engel, who is a psychiatrist and medical writer, wrote this statement. We want to ask, is there still an art to the practice of medicine in the 21st century, and what are these barriers? And Sarah Berger, who is now the chairman of the Obstetrics and Gynecology Department at the University of Buffalo, in her long and industrious career as an infertility specialist and a researcher, came to speak at Yale and used this statement that we want to try to do the most with the least use of technology. Just think about that. Do the most with the least use of technology. We know how wonderful innovation is. We couldn't live without it right now in medicine, but we want to make sure that we parallel our use of technology with our use of humanism, of our use of being able to relate to our patients and not rely solely on technology. A good example of this is, at one point, when a patient would come to an emergency department, they would come to the emergency department, they would see the triage nurse or triage person, they would see a physician, the physician would do the examination, the physician would then decide what tests to order and then order the tests. If you think about it, many times now you go to the emergency room, at least my experience has been to see this, that you see the triage person, and the first thing they do is order a CAT scan or an MRI scan or an ultrasound, and then they see the physician. That is using technology first. It may be efficient, it may be an efficient use, but let's think about more hands-on. We need to teach medical students now not just to use the technology, but also to use their hands, to use their diagnostic skills, to use their physical examination skills to touch the patient. Touching the patient is therapeutic. And if it's going to be the barrier of technology that's going to be between the healthcare professional and the patient, then that's going to just produce more and more barriers as that patient goes through the workup, so to speak, when they're in the hospital trying to figure out what's going on. So one of the struggles that I've had in thinking about all of this is, what does humanism mean? You know, we talk about being a humanistic professional, a humanistic doctor, but I really thought, you know, how can I define humanism? What would be the best way of stating that I'm humanistic, you know, or you're humanistic? So I've come up through the literature in putting together some of these ideas. So the first is a dictionary definition of humanism, that it says that from the American Heritage Dictionary, that it's the concept that the concern for human interests, values, and dignity is of the utmost importance to the care of the sick. I like that statement, and I think it's one of the statements I'd like to put together for how we define humanism. Now, let's think about humanism and mindfulness. which is mindfulness being described as a calm, purposeful, and reflective presence. This statement from Dr. Singer and Riff, through humility and continual self-evaluation, mindful individuals, such as physicians, become tacitly aware of their own limitations and continually address these deficiencies through everyday actions with their patients, with their families, and other professionals. So I like this statement, humility. Humility is something that many times is lacking. I always have strived and teach to the medical students, and I still do teach at Mount Sinai, that humility is an extremely important trait when we're taking care of patients. We never want to be egocentric. We want to be humble and be able to empathize, because that's the only way, through humility, it's the only way you can be empathetic. And so humility and self-evaluation, I like those terms in describing what humanism is. Some other statements: if medicine protects life, then literature interprets it. Here, bringing into the concept not only of practicing medicine, but using literature, poetry, prose, song, perhaps, all of these modalities to try and calm and heal. And then Dr. Parsonet, who was at the Stanford University School of Medicine in California, wrote that there's a need to learn how to teach the important empathetic art skills of medicine. And a nurse practitioner whom I worked with when I was at Yale, she's at the Yale School of Nursing, wrote, "It's no longer acceptable to know our own worth," and she was speaking of nurses, but it could be for all of us, "and not attempt to articulate what it is that we do, see, feel, and provide to our patients, families, and communities." And then Dr. Schultz from the University of Texas Medical School wrote in one of his writings, "I implore you, as you progress in your studies, don't ever treat your patients like case numbers, a disease in need of a cure. They are people who have feelings, loved ones, and aspirations. Become a healer, not a repairman." That's a very powerful statement. Hippocrates wrote in one of his other writings, "Cure sometimes, treat often, and comfort always." I believe that it's the healthcare professional's role to bring comfort, to heal, because from such healing comes self-reward, self-fulfillment, and honor. If we are surrounded by despair and inequities and have the opportunity to help with their dissolution, it is our obligation to do so. To the left is a tablet that I did get from the internet, but it's a tablet that represents the Hippocratic Oath. And one of the things that I have spoken to my students about and have written about is this statement, that we who have taken the oath to practice our sacred profession of medicine with an imperative to respect the sanctity of health for all those we treat, with a sense of high privilege, for they are the flesh and the blood and the souls of all humanity, past, present, and future. And we, by our choice, us, those that are in the health professions, those that are at this conference today, you represent the future. You are going to be their guardians. No matter what aspect of your care, of the care of your patients, of the people that you're thinking of when you're learning, you're going to be the guardians. That's what we have to think about, that we are the guardians of these people's health. And that's our responsibility. Maimonides, who was the great rabbi and physician of the 11th century, wrote, My lofty aim is of doing good to thy children, and may I never see in the patient anything but a fellow creature in pain. And that the physician should not treat the disease, but the patient who is suffering from it. Similar to that other statement that I wrote about, that we should be the guardians not only of the disease but of the patient. The patient comes first, because the patient represents not just the disease, the illness that they have, but all of their psychosocial, environmental, and family historical importance that they bring to you as their physician. And that we have to have an objective detachment to be reflective, to have reflective participation, so we can infuse our care with greater warmth and caring. Now, this is a statement from Dr. Sherwin Newland. Dr. Newland was actually a friend and a colleague of mine at Yale, at the Yale Medical School. And he left his general surgery practice to be a full-time author. He had started writing when he was a surgeon, but he wrote multiple books. This is a book pertinent to our talks today and your talks as we move on in this course on how we die. It's a book that he wrote. He calls it How We Die, Reflections on Life's Final Chapter. I was honored to be not only a friend of Dr. Newland's, but he was my mentor and I was his student. And he actually helped me with the writings that I've done. And Dr. Newland wrote this book and became actually, he won the National Book Award, which is one step down from the Pulitzer Prize, from this book. But he's written multiple books. But I was honored to have him write the forward to the book that I wrote, certainly not of the stature of this book, but a book that I wrote on pregnancy loss called Parenthood Lost. And he wrote this in the forward. And I think this symbolizes what I'm trying to say when I am trying to define humanism. And only someone of his stature and his writing ability could put it in such beautiful language, what I feel is beautiful language. And this is what he wrote. The physicians of the Hippocratic era called medicine the art. They knew that the care of their fellows was an act of creativity. They also recognized that each patient and his or her physician form a bond that is unique unto itself. And that bond is the foundation upon which healing takes place. The bond's formation and maintenance is the fundamental aspect of the art, no less a creative act than is healing itself. It goes beyond the notion of mere empathy and sometimes comes very near to being a form of love. It is when we cannot cure that the bond of patient with doctor reaches its ultimate challenge. So I want you, just to think about that when we think about what it is that we're trying to do for our patients in this humanistic environment. So on the left here, you can see what I put together as technology today. Certainly, there are many more technological innovations, but I want to take you through a couple of these and just talk about them. On the upper left is an earlier ultrasound of a fetus. All of you have most likely seen ultrasounds. They're much more well-defined now. But this is one of the most amazing technologies that we all take for granted. But I have to tell you that when I was in the 1970s, when I was at Yale, ultrasound, fetal ultrasound was really pioneered there by one of my professors, Dr. John Hobbins. And it's come a tremendous way. But this was a tremendous innovation using ultrasound. The other represents a fetal heart rate monitor, many of you who are involved or maybe have been pregnant or involved in pregnancy, families been pregnant, studying this, have recognized that this is a fetal heart rate monitor tracing. Fetal heart rate monitoring has been around since the 1970s and is ubiquitous now all over the world, and is a major innovation in trying to prevent intrapartum deaths. This just represents informatics, right? Amazing amount of technology. Right now, we're in this new world of artificial intelligence. So that's really what this represents. This represents an ultrasound picture, albeit early picture of quintuplets. You can see 5 sacs here, 1, 2, 3, 4, 5. This represents the paradox of technology, that it's amazing that, and you're going to get a great talk if you haven't had that already, about in vitro fertilization and the ethics behind that. But in the early days, women were given multiple embryos, implanted multiple embryos. The technology was there. They had quintuplet pregnancies. You can see 5, and almost none of them would survive, except the very rare instance that we hear about in the news. And, it's the paradox of this great technology of in vitro fertilization and artificial advanced reproductive technologies, but the paradox that the babies died. This fortunately no longer exists, but I use this as an example. This just represents DNA technology, the fact that we're in this new era now of personalized medical care. And this represents apoptosis. You can see that this is just a cancer cell being destroyed. And this represents messenger RNA that we all know about in the development of not only vaccines for infectious prevention, but also probably to help us in our cancer therapies and other immunotherapies. But the fact is that in the 21st century, where we are today, despite the exponential availability of these technologies, there exists the paradox. This is what I really want to bring to your attention today, that there's this paradox that these technologies succeed only for some, that we as physicians have been granted, as I believe, by oath and by ethic, that we have the privilege to examine and treat, to counsel and advise our fellow human beings while using these technologies. I mean, that's what we're all learning, right? But we must recognize and heal the unspeakable losses evident when medicine and technology can no longer treat, and the physician or health professionals can no longer cure. This is a map of the rates of stillbirths throughout the world. And I bring this to your attention only because I want to bring up the importance of understanding and recognizing the social determinants of health. And in this case, the world's health and how the disparities exist. And pregnancy loss, stillbirths, and if we expand that to infant loss, the infant mortality rate, which is really from the time of birth to the first year of life, is actually very parallel to the stillbirth rates throughout the world. It's not exact, but it's similar, very similar. And if we think about the infant mortality rates, the health of countries throughout the world are gauged by infant mortality rates. So just extrapolating that to pregnancy loss, stillbirth rates, I want you to just see the disparities that exist here. The blue represent the industrialized countries, right? We have North America, we have Eurasia, Australia. These are the countries with the lowest perinatal mortality rates, the lowest infant death rates. Overall, globally, there's a 1.3% stillbirth rate. In industrialized countries, it's 0.3. It's much lower than that. In in developing countries, particularly in sub-Saharan Africa, which, if I recall correctly, some of you are from these areas. If we look at those rates, they're 2%, 2% death rates for pregnancy. That's extraordinarily high and much higher than the rest of the world. So this statement from the World Health Organization about the social determinants of health really apply here. That the social determinants of health are conditions in which people are born, grow, live, work, and age. These circumstances are shaped by distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities. The unfair and avoidable differences in health status seen within and between countries. Just think about us. Think about the idea of us as practitioners, as possible healers, trying to heal and trying to help families in sub-Saharan Africa, for example, where there's no access for hours or miles and miles to cesarean section. Let's use that because I'm familiar with that. So that as much as we want to be able to apply all these humanistic endeavors, all our learned and creative skills to help that mother have a healthy baby, we can't do it because there's no electricity, there's no access to cesarean section, there's distances between families and healthcare centers. And how frustrating is this for those that are trying to do the right thing but can't do it? So I just put this in here as a plea to understand this, and I'm sure you understand the social determinants of health, but to recognize this as one of our frustrations for curing, being as a barrier. Now, I would be remiss if I didn't mention the role of not only physicians and other health professionals, but the role of nursing in caring for patients in the humanistic approach to patients. I'm a very strong proponent of nurses as part of my healthcare team, not only nurses, but nurse practitioners and anyone in the nursing profession. Many times in the past, it's been denigrated as the doctor's assistant, but in reality, nurses have their own identity and are able to heal in ways that we can't. So I want to just recognize nursing here in this whole healing process and recognize this is Florence Nightingale. She's sort of the symbol of nursing, and she gave up a life of luxury and went against her parents' wishes to pursue nursing in 1844. And as a nurse, she was so dedicated that instead of sleeping, she did nighttime rounds to tend to patients while carrying a lamp, hence her nickname, the Lady with the Lamp. Some of you may have heard of that and read about that. And that Queen Victoria awarded Florence Nightingale what is now known as the Nightingale Jewel, along with a reward of $250,000, which was an amazing amount of money in those days, which she used to fund a nurse training school and a hospital. And she wrote that nursing is an art. Remember, I mentioned to you that Dr. Newland wrote that as well, that we are in the art of medicine, that she wrote, the nursing is an art. And if it's to be made an art, it requires an exclusive devotion, as hard a preparation as any painter's or sculptor's work. For what is the having to do with dead canvas or dead marble compared with having to do with the living body, the temple of God's Spirit? It's one of the fine arts. I had almost said the finest of fine arts. And I use the word, again, this is from Florence Nightingale's writings. I use the word nursing for want of a better. It's been limited to signify little more than the administration of medicines and the application of poultices. It ought to signify the proper use of fresh air, light, warmth, cleanliness, quiet, and the proper selection and administration of diet, all of at least the expense of vital power to the patient. In other words, yes, use the administration of medicines. Let nurses be able to do that, but also to use these intangible skills, intangible concepts to help in this whole healing process, which is very, very important. Now, going one step further with nurses, again, thinking about our topic today of healing but not curing, I want to talk a little about hospice. The recent years have brought us to the health in the health professions and to the public an increased awareness to the need for tools to provide a compassionate and appropriate approach to the management of perinatal, childhood, and adult death. In other words, end-of-life care. And what could be more of a paradigm than end-of-life care than thinking about the origination, the development of a hospice, a center or a group of people that are helping those that are mortally ill and are about to die, no matter what that time frame is from diagnosis to death. And I want to talk just quickly about the history of hospice. This picture on the left is actually the modern St. Christopher's Hospice in London. And this is the hospice in the United States. This hospice, as is described down below, is the first hospice, and it was in Connecticut. Believe it or not, it's in my hometown. I live in Branford, Connecticut, and this hospice is less than a mile from where I live. And this is an inlet from Long Island Sound, and I can actually see this from where I live, the hospice. I don't know if that's symbolic or not, but it is what it is. And the Connecticut Hospice was America's first hospice. It was founded by Florence Wald and a group of nurses and doctors and clergy in 1974. But prior to that, Florence Wald, who was then an associate professor and dean of mental health and psychiatric nursing at Yale, was inspired by a lecture given by Dame Cecily Saunders. And Cecily Saunders founded the St. Christopher's Hospice, which is probably the most famous hospice in the world. And that was in 1967. Now you can see, 1967 is almost 60 years ago, but you can see that in the whole scope of eons, only in the last 60 years was this whole concept of hospice created and developed and grown. I've had some personal experience with hospice with my mother, and when she died, we didn't have her in hospice. We had home hospice care. So hospice care can be either in an institution, or at home, but it's not the physical building. It's the people that are in the building. So it's very important to think about, we're thinking about people, we're not thinking about institutions. Now, we as health professionals must grasp the concept of presence. I am a firm believer that we have a very important role in helping our patients when they cannot be cured. And it's our presence, our being with them, and our being in touch with their feelings that are extremely important. And that our words and our deeds, when our patients are dying or are incurable, or their families are grieving, these losses, or either perinatal loss, infant or childhood loss, and adult death. Everyone, that includes not only the doctors, that includes other family members, it includes you and other health professions, you as students of the health professions, everyone who touches and speaks and interacts with a patient, both in a primary and a secondary role, should be aware of what their lifelong influence on healing for the patient and family can be. I don't think many people think about this, but I'm going to tell you and hopefully show you as we move on today how important this is for us, how important that relationship that we hopefully can develop and maintain with our patients, even in death, even as they're dying, even with their families, is so important to help those patients before they die and their families after they die in this whole healing process. Now, as an example, I want to show you this gravestone. This is a gravestone in a cemetery in New Haven, Connecticut, where babies back in the 1980s and 1990s, and actually even in the early 2000s, babies that died that were stillborn, babies that were 5 months or 6 months stillborn babies, were buried in in a mass grave site in this cemetery in New Haven. And when I got involved in this, I learned from a lot of families that they wanted to know where their babies were buried, and none of them knew. This was all done in sort of silence and in privacy, secrecy, and they wanted to know where their babies were buried. So we were able, with a group of bereaved parents, were able to investigate this and found that there was this cemetery in New Haven where the babies were buried in a mass grave. And we were able to exhume the bodies, the remains, not the bodies, but the remains of these children, and create one gravestone, which is what this represents here, this gravestone. This is an actual photograph that I took at this service. This was back about 20 years ago, 15 years ago. And at this service, all the parents whose babies the remains we were able to find were re-entombed in this area with flowers, with a gravestone, in a place where now parents could come and be able to memorialize them. And it's so hard to understand how important this was to do. I really don't take credit for doing it. I just helped, I was part of it. But it was really the bereaved families that did this. And it was so important that they actually wrote an article in our local newspaper. And in the local newspaper, they talked about this service, and they talked about how the babies that none of the families knew where their babies were buried, now knew where they were be entombed. And I got a call in my office one day from a mother of a woman. She was in her 60s. Now, she was in her 60s, and she said, Dr. Berman, I read about this service, and there hasn't been a day in the last 40 years that I haven't thought about where my son was buried after I lost him at Yale New Haven Hospital. And she knew that's where she had her baby that was stillborn. And at that time, there weren't private burials, there weren't funeral services for babies, and all these babies were entombed buried in this mass grave. It was unmarked, no names, right? And she said, can you help me find if my baby's remains are there? Now, the point of this isn't that she called me up and wanted to find out where her son was. The point is how enduring the devastation of a stillborn baby is to a mother, to a family, that for 40 years now, she already had the rest of her children, she has grandchildren, but now she's thinking about the son that she never stopped thinking about. So I bring this to your attention because I want you to understand that the impact of these, in this particular case, these stillborn babies, the impact of these losses are lifelong, are lifelong. When we had this service, I was asked to say a few words, and I wrote this poem that I dedicated to all of these children lost. The name of the poem is called Martyr for Desire, which I'd like to share with you. You are my quiet darling, your eyes like morning burn, the minutes of futility to contrite hours turn, eastward where begins the dance of ocean tides and slumbers still, the famine of our grief to hide so deep within my wounded will. A promise poisoned from the start, so brief without reply or song, did graze your spirit in my field. Return to me, I cry, I long. As chaos prods my anguish, yet neglecting fortunes in my soul, tinted hues of destiny are tender thoughts which sorrow stole. From me when first I heard your voice, each murmur on your breath that sang, like harps converging as a choir, and chimes afar with passion rang. You are my quiet darling, within a cold and flameless fire, and I a prism in the shadows, a silent martyr for desire. So I talked a lot about privilege and presence. And I really, since I thought, and I'm sure all of you feel this way, dedicating yourselves to the health professions, to studying the ethics of what we do in our daily lives to help others, and what's right, what's wrong. We all have a privilege. And I have always considered being a physician not to be taken for granted, but to be taken as a privilege. And that privilege is we are actually interfacing with our patients in the most intimate, metaphorically intimate way. We are delving into their minds, we're delving into their bodies, and we're trying to cure them. And nowhere can this be what I believe more important. I shouldn't say nowhere, but where this is most important is thinking about surgery. And I want to just give you a little story. And for those of you who are medical students at this time, this may be very pertinent. I was operating on a patient. It was a day that I had two successive major abdominal surgeries scheduled for two patients. And I was operating on the first patient. And in the operating room, aside from the nursing team and the anesthesiologist, was the resident. I always work with a resident. I always work with a medical student, a third-year medical student. And the third-year medical student and the resident, at the completion of the surgery, the normal routine would be to finish the operation. I would wait in the operating room because I always wanted to wait for my patient to awaken from anesthesia. And the resident and the medical student would go to the doctor's lounge, write the orders, have a cup of coffee, and get ready for the next operation. That was the normal process, and it still probably is. Now, in this particular instance, this day, I completed the surgery, patient awakened, and now I went to see my next patient in the preoperative area. And I found that when I went to see my patient, the third-year medical student hadn't gone with the resident, but the third-year medical student was there talking with the patient that she was going to be assisting the surgery with. And I noticed that they were speaking Swedish. My patient was from Sweden. She spoke English and Swedish. And the medical student was from Sweden, which was just coincidental. So the medical student was speaking with the patient. And the patient said to me, I'm so glad that I was able to have the medical student talk with me ahead of time. It makes me feel so comfortable knowing who's going to be in the operating room with you, Dr. Berman. And I was astonished because this is the first time I had seen this. The medical student didn't have to ask my permission. I mean, I was certainly glad that she did that, but it was just something that she took on her own initiative. So we went back to the operating room, and the patient was being prepared for surgery, and I was scrubbing with the medical student. And I said to her, I told her how proud I was of her and what she did. And we talked about this whole idea of privilege. And I said, just think what we're about to do. I said, we are going to take the sharpest instrument we can find, right, which is a scalpel, a medical grade scalpel, and we're going to take this instrument and we're going to make it a major incision in the patient's abdomen and do the surgery that we have to do. And that patient is trusting us, me and you and my team, to do this and safely and correctly, right? And help her in this way. And just think about what a privilege. Who else has this privilege of being able to, and I use this as I spoke about this, have spoken about this and think about this, it sounds a little, and I don't mean to be funny, but it sounds a little corny, but whoever thinks about this when they're operating, you go in, you operate, but I'm thinking about this with the student. I'm saying, just think, we're taking this sharpened knife and cutting into a patient's abdomen intentionally. And I said, this is a real privilege. That privilege, I don't think can be duplicated anywhere. And it can be extended, though. It doesn't have to, the scalpel is the metaphorical instrument, right? We're cutting into the abdomen. But when we're talking to a patient, when we're talking to a family, we are talking with a sense of privilege. We're asking questions. We're being able to delve into their minds and figure out what's happening to help them. This is a privilege that only we in the health professions have, I believe. And it's really what makes our professions stand out. So I wanted to relate that story to you. Now, presence, as I mentioned before, being immersed in what we're doing is extremely important in medicine and in caring for patients. We have to be there, mindful and present all the time. We can't have our minds wandering. We can't think about how long it's going to take to interview a patient, to talk with a patient, to care for a patient. We have to do it with complete dedication and what I call immersion and confrontation. If there's a problem with the patient, if the patient needs additional attention, we need to be proactive, confront the problem, and immerse ourselves in it until we're exhausted and we've exhausted all the skills and knowledge that we have. And if we can't do that, then we have to get another opinion, we have to get other help, but it's our responsibility. And we have to have open and uninhibited communication with our patients. We have to make ourselves more comfortable. We have to learn this. And this can be learned through mentoring. This can be learned through shadowing others. But we have to learn to make us feel more comfortable talking about this difficult subject of severe illness, of death, and of dying. And this is what we're talking about today. We have to be comfortable with this. And none of us are comfortable. Someone once said to me, and was actually after the book that I wrote about pregnancy loss, when that book came out, someone once said, boy, it's so nice to talk to you being an expert in this. I said, I'm not an expert. I said, you can't be an expert in this. Every patient is different, and every situation is different. And if you think you're an expert, then you're not having that humility and being contrite about it. Because when you're dealing with the death of a patient or the death of a baby or the severe illness of a baby, you need to bring your expertise there to take care of them. But I would hate to be thought of as an expert in care of the dying. What I want to be is an expert in the care of another human being. And I think that's what's really important. But every time you're in the emotional circumstance of caring for a patient who's dying, it's a unique experience. Every patient is unique, and we have to treat every patient as they are unique. And that's what I hope you'll, one of the tenets that you'll take from this talk about presence and about personal attention, because I purely believe that that is a crux to helping our patients get through these difficult times. The care of the dying patient or the incurable tests not only our clinical skills, as I mentioned, but it stretches the fibers of the human aspect of caring very thin. And as I mentioned before, what do we do when the advanced technologies that we have at our fingertips that become part of what I like to think of as the black bag, right? In the old days, doctors used to carry around their black bag, stethoscope and reflex hammer and blood pressure machine and tuning forks and medications. That was the black bag then. Now our black bag is all of the advanced technology. But what do we do when that fails? We have to understand that we can heal by providing comfort and empathy and hope. And as bad as this experience is for our patients, we can make it better. If we remain aware that we are this link between our patient and his or her family and friends, then we can share with them, we can remember with them, and from this point forward, heal with them. Thus, the bond that we form becomes the unbreakable fiber that strengthens and indeed cements our role in the doctor-patient relationship. To be a physician, and now again, I'm extrapolating this to all of us in the health professions, in the bioethics professions, etc. But to be a physician, and particularly to care for the critically or terminally ill patient, is a time for searching and yearning and painful emotions. And that the service of medicine is not a relationship, and you've heard this theme before, between an expert and a problem. It's a human relationship, a work of the heart and of the soul. Now, this last statement is written by a doctor. Her name is Dr. Rachel Berman. She is a pediatric oncologist at the University of California, San Francisco. She's written a lot about the doctor-patient relationship and the human experience. And she wrote an amazing article that I would recommend that you read. It's called Recapturing the Soul of Medicine. And I'm very honored to be able to cite her work here. So I want to give you an example from a patient of mine. Her name was Susan. Susan, just to give you a little background, I'm going to read this, but to give you a little background, Susan was a patient of mine the first week I went into practice, and that was in 1977. I actually went into practice in the early summer of 1977, and she was one of my first patients. And I took care of her for her entire, from that time on, my entire career would see her. okay? And she ended up, unfortunately, becoming very, very ill and dying. And when she died, I asked if I could say a few words at her funeral memorial service. And this is what I wrote about Susan. Please know what an honor and privilege it is for me to have the opportunity to write and speak these words today. I am so grateful to Susan's family for this time. It was in August of 1977 when I first met Susan, just 3 months after I opened my medical practice, nearly 33 years ago. So she was a patient of mine 33 years. Susan was among my first patients. Now, as you know, most patients see their doctor once a year for annual exams and perhaps for a few other interval visits. For Susan, this came to about 32 plus visits, each lasting perhaps 15 or 20 minutes. In a lifetime, not a very long duration of face-to-face time with each other. How, you might ask, then could I know enough about Susan that I could even think to ask you, her family, to speak some words for her at this time? Let me explain. In an effort to best understand my patients, I spend a good deal of office visit time talking with them so that I can better learn about them as whole persons, know and remember their lives and persona, so as to best help them with their medical needs, what might be called a patient-focused or patient-centered approach. From year to year, Susan's persona was unforgettable. She never spoke a word of negativity or complaint, never disparaging anyone, and always answering my question, "How are you doing, Susan?" with an immediate counter question, "How are you, Dr. Berman?" Always putting herself second and thinking of others first. Even when her courageous spirit was summoned to the very core, when given her ultimately fatal diagnosis, Susan remained positive, hopeful, and free of anger. Susan traveled through her world these past few years on angel wings, in a world that many would consider mired in tragedy, despair, and suffering. I am so saddened by Susan's death. I am saddened because we have lost a person so righteous and good, so sensitive and caring. Her truly beautiful being, which will remain forever, is her gift to us to remember forever. I am saddened because when a friend or family member dies or a patient dies, we regret not saying that one last word or making that one last trip, or in my case, spending more time with her and her loving family when she was living rather than when she was dying. Susan actually had two cancers during her lifetime. She had breast cancer, which she actually was treated and cured for, and then she had metastatic melanoma, which ultimately caused her death. I finished this eulogy with a poem that I wrote for her, and I'm going to share that with you. It's called Angel Wings. I live my life on angel wings, traveling not too distant miles, yet high enough to feel the wind whisk my face to turn a smile. I found my gift in those I love, knowing love was always there. As songbirds sing and flowers bloom, I never doubted those who cared. I learned so much from every day about the meaning of why we live. My wish will be my legacy, a wish to never cease to give. I never want to hurt or harm or leave my loves with tearing eyes. For you I plead, rejoice and praise in what we shared before I died. So now the daylight streams so bright as church bells chime and choirs sing, and I to rest in earthen walls, my soul to soar on angel wings. One thing about Susan, and as I mentioned in that eulogy, I'll just go back to that for a second, is almost everything that we've talked about thus far in this presentation. The fact that I felt so privileged to take care of her as her doctor when she was well because of that was my responsibility. And when she became sick, I was able to take this bonding that I had with her just as another patient and be able to use that to try to help not only myself in expressing how I felt about her as a person, as my patient, but also to help her family. So hopefully you'll understand that all of this rhetoric that I'm saying really has real uh, grassroots and grounded uh, value in what we do each day. And I don't think I could have practiced medicine, nor do I believe that medical students, as I teach them and talk about this with them, could even think about being in their medical profession without thinking that this is what they're going to have as well. Because I know it's what made my profession the most fulfilling that I could ever imagine. Now, I want to talk a little about mysteriousness, because even though I'm a very scientific, objective person, there's sometimes in our daily routines of caring for patients and actually in living, we have situations that seem mysterious. And this is a story about a patient of mine who was, again, one of my first patients, and I had the privilege of caring for her for 30 years. And we sort of grew up together. I watched her, um, I watched her life unfold. I was able to what I call share in her blessings and her adversities. And we enjoyed an envious rapport as doctor and patient. And as a young woman, this patient was afflicted with a curable cancer. It was a type of lymphoma, and she was treated for it. However, she was treated with radiation and chemotherapy. And she did have a child, even though it was remotely possible because of all the radiation and chemotherapy that she had, but she did conceive and had a healthy son. However, the radiation unfortunately affected her heart, and she developed this post-radiation cardiomyopathy and was in heart failure. And she awaited a heart transplant for 2 years. Now, because I was a faculty member at Yale's University at the medical center, I knew a lot of the doctors there. And she actually went for a heart transplant. And when she went for her heart transplant, I asked the cardiac surgeon if I could be in the room with her. And I was fortunate enough to be able to do that. So I don't know if any of you have ever seen a heart transplant, but I had never, here I was well into my career, had never seen open heart surgery, never seen a heart transplant. But in the operating room, I was able to hold her hand because her husband couldn't be there. I held her hand as she went under anesthesia, and I watched the surgeons remove her heart and transplant her with a healthy heart from a donor who had just died within 2 to 3 hours, actually, in a motorcycle accident. The new heart she awakened, and it was amazing. It was an amazing experience for me. I was glad I was able to be there. But she suffered for 2 years afterwards, or maybe even longer than that, with post-transplant problems and rejection, graft-host reactions. And finally, she became fatally ill and was in hospice. And here's how the mysterious comes in. So every Thursday, I would go to my office and then drive to the hospital Thursday afternoon for grand rounds. On this particular Thursday, well, let me go back. The patient now was in hospice, which I mentioned to you was in my town of Brantford, where my office was. Now, every day I would go visit her in hospice. That was my routine because I wanted to be with her every day as she was in hospice. And it was easy for me to do. I just went from my office to hospice, and then I would go to the hospital to make rounds. I did that as a routine. This Thursday was a day that we were having ethics, bioethics grand rounds, and we were going to talk. The ethicist was going to speak on the ethics of the doctor-patient relationship, which I thought I wanted to hear. So I decided I was going to go to grand rounds Thursday afternoon. As I drove by the exit to hospice, I said, something is compelling me not to go to grand rounds and go to hospice. So I detoured and went to the hospice and went to her bedside. And her husband and her mother told me that she was about to die. And they were sitting at her bedside. I was there, and they said they were going to go. The husband and the son were going to go and get something to eat, and I would be there with her mother. And while they left, I was at this patient's bedside, and she died. She died when her family were actually away, because I think she waited until they weren't there to save them that pain. But I was at her bedside when she died. And I consider that mysterious. That's something that is intangible that drove me there. I think about that all the time because I think here I was going to a lecture about the doctor-patient relationship, and here I was actually being the doctor with the patient. So I wanted to share that with you. This is a poem that I wrote for her. It's called The Covenant, and it talks a little about her travails during her healthcare issues during her life and her attitude. That it's called The Covenant. I am an artisan, a painter of hues and fading, to blend upon my palette infinite promise, and emblazon on my soul a landscaped canvas, stretched to infinity between pillars of prayer, neither stalked nor conspired against am I. Only fate has become my betrayer. And although the defenses of my mortal flesh have weakened, the borders of my body and the cisterns of my soul are strong and alive with pulses of blood and liquors of hope. I will not lament nor ask of this from you. I will not know defeat or the wrath of any pain, for I, like a solitary seedling that yearns to taste the falling rain, know well that God's eyes alone will shed but triumphant tears upon my brow for me and for my covenant of victory. It's interesting that this patient also was a virtuous patient, like Susan was before. And she actually taught me so much. As I think about, many of my patients have taught me so much through the years. It's really it's what made things so fulfilling, what makes it so rewarding for us in the health professions to be able to be part of our patients' lives like this. So it was really amazing that we were able to have this relationship. The second instance of mysterious I want to share with you is of Andrew and Joseph. These are two babies that were stillborn at 20 weeks. And the reason this is mysterious is it has to go back to a little story. This is a picture of the double helix, DNA. And I was asked to give a talk. It was one of the first major perinatal bereavement lectures this one was in Baltimore. And the name of the lecture was called The Long and Winding Road. And in preparing for this lecture, I used this as a symbol, this long and winding road, really the double helix of the DNA, as a metaphor for that long and winding road. And in this, I was talking at the lecture about the history going back to prehistoric times on the role of burial and of stillborns, even back in prehistory. And I talked about the ancients, and I talked about current issues, and it was a very rewarding lecture. Now, this was scheduled months ahead of time. The 3 days before I was about to leave to go to the lecture, one of my patients who had endured several miscarriages was currently pregnant with twins. And she called me up and said, I think I'm in labor. And in reality, she came to the hospital and she had two babies died. She had twins that both died at 20 weeks of pregnancy. And I was going to plan to induce her labor, but I couldn't be there because I had made this commitment to go and talk about this lecture on the long and winding road about the history of perinatal loss. So what a coincidence. I'm going to talk about this, but I can't be with them when I wanted to be. I mean, this was something I wanted to do. I wanted to be with them, be with her when she delivered these babies and be with her to help her, but I couldn't because I had to be out of town. So I gave this talk. Now, I left, and my partners who were part of our team were able to take care of. Now, this is the mystery. In my talk, remember I talked about prehistoric times. I talked about the Shanidar baby. The Shanidar baby comes from the region of Iran, where the Shanidar caves lie. And in the Shanidar caves were found the remains of prehistoric babies that had died and were buried with a ritual burial. That ritual burial included throwing wildflowers into the grave. And the archaeologists knew this because they found the pollen microscopically, were able to find pollen of wildflower seeds, right? And I talked about this in this lecture because I thought it was so powerful that back in the 27,000 BC, they were doing ritual burials, just like we were practicing now in modern times, having funeral services and memorial services for babies. And here they were putting wildflower seeds into the graves. So I talked about this. This is just another picture of the Shanidar skeleton, okay? And I came home and found a letter from my patient, Andrew and Joseph's parents. And in that letter, unbeknownst to them, what I was talking about at this lecture was a packet of sunflower seeds. You can see these seeds, wildflower seeds, that were placed in Andrew and Joseph's grave. Now, to me, that was part of this mystery, this mysteriousness, this caring for patients, and then finding that there's this symbolism. I talked about this at this lecture, and then all of a sudden I come home and find these. I still have these. I keep these in my desk drawer. It's like to me, was very mysterious and very, very important, actually. Now, I talk about this personal journey, and you heard this journey, and I put this together in a series of writings and of lecture series. And initially, I started out talking locally about pregnancy loss. But I expanded that and developed a nonprofit organization called the Hygeia Foundation. This is actually a statue, facsimile of the head of Hygeia. Hygeia was the Greek goddess of health and healing. And we were able to provide through this organization bereavement information and peer support programs locally, and actually in the early days of the internet, internationally. And it became a very prominent part of the internet before Facebook, before the current social media sites. And I actually had a viewership, a readership of about 30,000 families internationally from almost every country, sharing their thoughts and feelings about pregnancy loss. That's sort of in the past because that's been replaced by the current social media sites, but it was very important in my development. I started this because I started thinking about what are my feelings about caring for these babies that have died, the patients. I mentioned to you the two adult patients, and now talking a little more about pregnancy loss, about babies that have died. And what are our feelings? What about the professionals and family members who care for those who have experienced pregnancy losses, neonatal deaths, childhood losses, and indeed those who care, like yourselves, for all of those at end of life care? For us, there also exists a remorse and a sorrow that can approach that of the grieving mother or father or family. And many times the grieving and sorrow that is felt is kept silent. We don't talk about it. We don't talk about it with our families. We don't talk about it with our colleagues. It's silent and it goes unnoticed because most of the time our attention is given to those that have experienced the death or the illness. And that's where our energies go. And that's where our attention goes. But we don't think about ourselves, which we have to think about. We have to have some type of system, some type of mechanism so that we can keep doing this because it's very draining, right? So I developed a system, and that system was basically a system to manage the grief that we feel. You saw the poem that I wrote for Susan. When I read that poem at her memorial service, I was crying when I read that poem. I felt so strongly about her death and about addressing her family and about her life, what a wonderful life she lived and how I was able to be her doctor. But I was crying doing that. I couldn't share that. I shared it with them, with her family, but I couldn't share that with anyone else. And now we've found that it's important for all of us and all of you in the health professions to be able to share these feelings amongst ourselves. And there are multiple program models now that are enabling us to do that. That there are medical school and nursing school programs that are able to, through mentors, through conferences, through support groups, and through actual didactic education, be able to help us integrate our feelings into caring for patients and how we can deal with the terrible situations when our patients are not curable. There's integration of the humanities and medicine. Many programs. I was fortunate enough to be both at Yale and at Mount Sinai in New York, where both of those institutions had very strong arts and humanities and medicine programs. And there are other hospitals now throughout the world that have what's called, and this is just a name, Icahn, or second victim programs. The first victim being the patient, being the victim of their disease, and us as their providers of care being the second victims. So there's a lot of recognition now in how we can support ourselves. But for me, that wasn't available. None of that was available back 20 years ago when I was starting to really write about this and think about this and was really in the the pinnacle of my career caring for patients. And I knew that I needed to fall back on something that would help me. And that fallback was self-reflective writing, that I was able to, through a catharsis, to find a way of sharing my feelings and my stories and my emotions. And once again, I go back to Dr. Remen. Remember, I mentioned to you about her, who wrote that meaning is a human need and it strengthens us not by numbing our pain or distracting us from our problems or even by comforting us. It heals us by reminding us of our integrity, of who we are and what we stand for. And it offers us a place from which to meet the challenges of life. And when we start thinking about this and when we have this self-reflection, I think we can really start that healing process when we're caring for such very sick patients. That inclusion and assimilation of art, literature, poetry, bioethics, law, end-of-life care, theology, and at its core, that humanism that we talked about, if we can infuse this into the education of medical professionals, we will help them appreciate that their life's work is your life's work is truly one of privileged human relationships. I believe that tears cannot adequately portray our grief as we begin this search, but our words, the words that we write, the words that we read, and the words that we hear can serve as an invaluable source of solace. I believe that words are songs from our hearts and can be songs of hope, songs for hope, not only for our patients, but for us as we take care of our patients. Hope, I believe, is a singular gift that we must never destroy. It's an endless song in an endless concert, a nocturne bright in the darkest of nights, and that poetry, for me, I believe that poetry can be the instrument of hope, right? That a synergy exists between poetry and medicine, for each share from their origins themes of life and death, sorrow and despair, love and futility, promise and hope. A simple poem can transfer frosts of despair and gleams of elation inwards when written on the occasion of a birth or a death, a tribute or a memorial, a secret feeling or a revealing epiphany. And that the impact of our words and thoughts at difficult times are universal. I know that all of you come from different nationalities, but I know that all of you, your words are universal because we're all a society of communicators. Through our speech and our literature, we portray ourselves just as paint applied to a canvas forms a portrait. We should not underestimate the influence of our words, for they are empowering. In a moment, they can help, and in less time, they can hurt. They can bring peace and they can create turmoil. And a few simple words in an appropriate situation, I believe, can have inordinate influence. A little more about why poetry is so important. Mary Jane Moffat, who is a poet herself, wrote, "The poet can awaken in a special way the emotions of those who feel wordless in the face of loss. And by making us stop for a moment, poetry gives us an opportunity to think about ourselves as human beings on this planet and what we mean to each other." That was a statement by Rita Dove. And poems are not just feathers drifting into the Grand Canyon. They can make a real connection with another mind and heart. That statement is by Dr. Liesl Mueller, by Liesl Mueller, the poet, who I mentioned earlier. And I was fortunate enough to send her a copy of my book that I wrote, and she wrote that as a personal letter to me, that poems are not just feathers drifting into the Grand Canyon. I thought, well, was so honored that she could write that for me. So my approach has been to do this reflective writing, because I was having trouble caring day in and day out with my emotions and taking care of the patients that I was taking care of whose babies were dying. And I needed to come back home and sort of meditate and sort of think about this, but I couldn't share it with my family. I just had to do it myself. So I started writing, and I talk about poetry because this is my method. You don't have to write poetry to do this. You can write your thoughts down in prose. You can do it in an artwork. You can do it in music. The fact is, you need to have some way of reflecting back on the experiences that are so intense, caring for patients that are so ill and who have died. But I started doing this, and I developed a collection of poems. I started writing poems for myself, but about my patients. And the first breach of this privacy was that I decided to send a poem to a patient as a form of a first condolence note. So I took care of a patient. I'm going to share that poem with you in a minute, whose baby died, and I was going to attend the service, but I decided to send the poem as a condolence note. I extended that to reciting a poem at a funeral memorial service, which I found, to me, was the turning point in my career when I first did this, and I'll share that with you as well. And then I created this organization that I mentioned, and all of this was a catharsis. All of this was a way for me to sort of expand what I was doing with the doctor-patient, that one-to-one, to try to help more people. And then I wrote this book to honor my patients, this book that I mentioned, Parenthood Lost. And now I'm trying to work in this new world of Zoom and lectures remotely in trying to help through the process of my website, Maternal, and also with my lectures to the medical students, a way of helping others deal with these very difficult situations.
So,
what's that?
Can
you please mute yourself? Thank you. Okay, so I'm going to just share with you a few of these poems, and then it will be finished. So the first poem is called Obstare. Obstare comes from the Latin word. It's a Latin word, and it comes the root of the word obstetrics. So you've all heard of obstetricians and obstetrics. In reality, obstare is a Latin word meaning to stand before. And that's how the word obstetrics became popular, and why we who are obstetricians are obstetricians. And this is a poem that I wrote to try to grasp my own feelings after a baby that I had just delivered at 35 weeks was stillborn. I have stood here before when birth deceived and surrendered to my hands the very spirit and soul of humanity, the essence of life save life itself. And I have touched before the angel hair and silken skin, a child lay bare, still and silent, in these outstretched hands, as my will cried out to scream a breath of life into his pale lips, her pale lips, now frozen in the mist of endless dreams. This next poem is about Cameron. This is the first poem now that I sent to a patient. I was very nervous about this because I didn't know how it was going to be received. And Cameron was a baby that was born at term with an unexpected diagnosis of congenital heart disease, what's called a hypoplastic left heart syndrome. At that time, there was virtually no treatment for Cameron, and he died after 4 days. And I wrote this poem and sent it to the family. I no longer see the stars, I am the stars. I no longer breathe the wind, I am the wind. I am the sweet smell of honeysuckle after an evening rain. I am the dew on the rose petals in early morning. I am harmony and I am peace. I am love. In sorrow, my mother and father cry, but they need not fear, for I am strong. My heart is whole and in union with my soul. I understand my fate and I smile, for nature's will is my destiny and my guide through eternity. This next poem is the poem that I mentioned, which I felt was the turning point in my career. And this was a poem written for Alexander. Alexander was born at 35 weeks, stillborn. And his parents, Alexander was their first child. And I was with the family in labor and delivered Alexander. And when Alexander was having his burial, his parents were actually they owned the funeral home, so they had to bury their own son. And they had a very large funeral, over 200 people outdoors. It was raining. And I wrote a poem for Alexander. And I went to the service and I went up to the priest and I said to the priest, I said, would it be all right if I said a few words about baby Alexander? And the priest said, yes, you can, but you'll have to take your turn in line. And I said, that's fine. So after the funeral service was over, the priest asked, is there anyone that has anything to say about baby Alexander? And out of the 200 plus people at the service, nobody had anything to say about baby Alexander. That wasn't because they were insensitive, but it's how do you eulogize somebody, a baby who has no history, has no accomplishments, it's very hard to do that. It's hard to say words about a baby you never knew. Then I went up there and I said, I do, and I have something to say, and nobody knew what I was going to say. And I had the poem, which I'm going to share with you in a minute, in front of me. And I'm holding this, shaking. I was very nervous because never in my entire career had I ever read any of my poems in public. But I recognized immediately that this was going to be impactful. And not because of the poem, but the fact that a poem, a verse, can talk in metaphor, in verse, in rhyme about somebody without knowing that person, and being able to eulogize a person and being able to fill the void in a funeral service of words that are not being able to be spoken. The poem is called Netzah. Netzah is a Hebrew word for eternity. Could I have died so soon that my cries were silenced in your womb, so soon that I'll never touch your breast, nor feel your hands caress my brow, so soon that you never got to sigh and cry sweet tears of joy for your first child, your firstborn boy? Could I have died so soon? I suspect not, for I felt the passion of your love around me as my heartbeat slowed, then stopped. As I lay motionless, I heard the misery in your cries that I would not be born alive and wondered why. Yesterday, Father, you fathered me. Today, dear mother, you birthed me. I was there, you were there, we all stood witness. I heard your whispers that you love me. I heard you tell each other how beautiful I was viewed in my eternal quietude. I even felt your soft caress as you held me to your breast. On this morn, mourn not for me. With ethereal grace, I have a name, I have a home, I have a life to live through all eternity. Now, the last poem I want to share with you, because I know time is getting short, is based on a baby, Theodora. And it brings into light pure ethics, modern day, contemporary ethics of what we tell patients, how we counsel patients. And I bring this to your attention, as I'm sure you all are aware, being ethicists and providers yourself, that it's so important that we have a shared decision-making model with our patients. And in the case of pregnant women, that it's not only a pregnant woman, but everyone has a right to base her maternity care decisions on accurate, up-to-date, comprehensible information and participate fully with their providers in discussing options. And we want to assure that the decisions that are made respect both the patient's autonomy and the physician's obligation to optimize the health of both the mother and the newborn. Obstetrics becomes, caring for a pregnant mother becomes very complicated because you're dealing with and I'm not getting into any of the religious or political issues of when human life begins, et cetera, personhood, et cetera. But we're dealing with the mother and we're dealing with the newborn. We're dealing with the mother and the fetus. We have to take both of them into consideration. And it becomes vital that we have what's called non-directive counseling. Non-directive counseling is another term for that, is options counseling, it's shared decision-making, it's being able to have a discussion, as opposed to directive counseling, where we're actually telling the patient, this is what we have, this is the situation, this is what we're going to do, we're going to schedule you for this. Non-directive counseling says, this is what the problem is, let's talk about that problem, let me explain it to you, let me give you references to read about it, as long as it's not, of course, an acute emergency, and we'll come up with a decision. I want to best exemplify this with this patient, Theodora. Theodora's mother was a PhD in psychology, is a PhD in psychology. Her husband, Theodora's father, was a PhD in engineering. I'm telling you this because I don't think we could have more informed patients than Theodora's parents. Very, very knowledgeable. And Theodora's mother was 40 years old when she conceived with Theodora through in vitro fertilization. At 13 weeks of pregnancy, her mother had a chorionic villus sampling, which showed that Theodora had trisomy 18. Trisomy 18 is a genetic disorder, as many of you might know, which almost always results in a fetal death, if not a newborn death, and if not an early childhood death. And it's virtually incompatible with a normal life. It's also known to cause early losses as well. But at 13 weeks, when Theodora's parents learned that she had this condition, they were told by the, someone mute that, please. Please. Theodora's parents were told by their doctor that your daughter has trisomy 18, she can't survive, and we're going to schedule you for an abortion. That's how it was presented to her. Her mother said to her, we don't want to have an abortion. We want to see Theodora born alive, if possible. We understand that she might die, but we want to be treated like any other patient, and we want to see what happens. And she then left that doctor and ended up in my office. And she said to me, when our first visit, she said, Dr. Berman, my daughter Theodora, whom I named, has trisomy 18, and I know that she might die. Will you take care of me? And I said, of course I would take care of you. And we talked, we spent a lot of time talking. I said, it may be that Theodora gets to full term. And if she does, and she has fetal distress, which I was expecting, would you want to have a cesarean section? And we talked about the ethics of that and the risks to the mother versus the fact that she would have a baby that would die. And did she want to take that risk? And she said she did. So we had that all planned out ahead of time. And what happened was Theodora did end up um, surviving her pregnancy, and she went into labor. Her mother went into labor. She had fetal distress. She was still alive in labor, but had fetal distress. We did a cesarean section, and Theodora was born alive. She was told by her, she was told by her prior doctors that she wouldn't want to see Theodora because she would have multiple birth defects. But this is a picture of Theodora. As you can see, she's was a beautiful girl. Um, Her parents were both from China. Theodora was born on the lunar eclipse, which was very significant. In Chinese, Theodora means the gift. And when the parents asked if I would say some words at Theodora's funeral service, which they had all orchestrated, I said I would. And I wrote this poem, and this will be the last poem that I share with you about a patient. And it's called The Gift. Um, Today the sun casts hues of hope, open eyes and grimaces, heartbeat flutters, angel cries, and then serenity. A life lived long enough to taste the sweetness of a mother's kiss, a father's kiss, caresses, and whispers and kisses again and again. Blessings, prayers, tears, moans of weeping, silent moments, raging thoughts, peaceful thoughts, which memories keeping. No shadows, pure light, eternal light, from sun and stars and moon glow, save the night of today, when the moon eclipsed turns umber, and Theodora be our gift forever. So, to conclude, we want to remember that all of these times are a time for searching and yearning and painful emotions. And we want to we want to formulate an individual approach which can permit each one of us to channel our energies to provide our patients healing, comfort, and hope, even when cure is not possible. I'm going to skip over some of these, and I want to just conclude with these thoughts. That we as health professionals, you as health professionals, must be honest with and express your emotions as you care for the dying or critically ill patient. That we can share our thoughts, and these thoughts can bond our patient with us as their healer. That caring fosters healing, not necessarily curing. That medical education institutions must embrace and foster programs to help their students and staff cope with these feelings. And reflective writing, such as my poetry, but certainly poetry for you, or prose and other forms of self-expression, can help come to terms with unexpected outcomes. And that immersion in the details and care of the patient and family can allay feelings of guilt and helplessness that we feel during these times when cures are absent and hope is lost. Then that we must have presence. And I'd like to end with this quote from Elie Wiesel, that just as despair can be given only by another human being, hope too can be given only by another human being. And I'm going to end the talk with this picture. I always like to share one photograph, and this is a photograph of me when I was younger, delivering a baby by cesarean section. This baby was born after her mother had a full-term stillborn baby 2 years prior. This was a joyous time, of course, for her mother. It was her firstborn child. And this is my third-year medical student that I mentioned earlier. I always work with a medical student. She was at my right side, and this is our resident. And that's the end of my talk. So I thank you very much for your attention. I'm going to stop sharing so I can see you all. And if you have some questions or thoughts, I'd be glad to take 3 minutes or as long as you want to talk.
Dr. Berman.
Hello, may everyone turn on, please, the camera.
So maybe
Turn
you could,
on your cameras.
maybe you could moderate this for me and then tell me who should.
Do you want me? Okay, good. Thank you. Thank you, Doctor. I hope they and they keep on being surprised day by day. Your lecture is definitely touching, moving, and it's not only because of the world context, is that you have always been in your presentation so emotionally and then emotionally appealing to the audience. So I hope because we have a couple of doctors here, or at least they are in the health field. I hope they would have a good lesson and they will tell the others about this lecture. Wonderful, and thank you so much. We will have a couple of questions here. Nora, oh, we kind of have Nora. Nora, you don't have a flower. There is always a Nora. Doesn't want a photo, but there is always a black spot. I don't like black spots, doctor. Okay, so yes, they will introduce themselves, please. Just say the country you're coming from. That's very important for Dr. Berman to know. And you can go ahead and raise your hand, and I will say go. Okay?
Is that hand?
There is a hand that they use it to chat, I guess, yeah.
Yes.
Okay, please go ahead.
I think she's muted.
Okay, Inchi. Inchi,
Yes.
unmute yourself, please.
Thank you, Dr. Berman, for sharing your memories. Your patient and colleagues are lucky to have you. It's great to have the opportunity to learn from you. Thank you, Dr. Anna, for giving me the chance to connect with Dr. Berman. Your web page will be shared with everyone around me. Thank you.
Well, thank you.
That's Inchi from Turkey. The next one, please. They're still meditating. Yeah.
Well, if you have any
Next
questions,
question, please. Peter?
I see Hannah Lee raised her hand.
Yeah, so just a sec. Peter. Peter is American. Oh, Hannah? Okay, sorry. Yeah.
Okay. Hello, I'm Hannah, and I'm a medical student in South Korea. I have a question about, and it's not directly related to the title of your presentation, like how to deal with people who are no longer treatable, but it's about the relation between patient and doctor. So I think you might be able to answer it. And my question is, I'm curious about how to overcome already deteriorated relationship between doctor and patient. Actually, currently in Korea, due to government policies that oppress doctors, many residents and interns have collectively resigned. And unlike the US, where most hospitals are dominated by specialists and professors, Korean hospitals have residents working 100 hours a week for minimum wage, so resignation has significant impact. Of course, when looking into this issue, there are problems such as patients not going to community hospitals which are left empty, but only flocking to specific university hospitals. And resident working to the point of exhaustion without receiving proper training, as well as issues where citizens feel both admiration and resentment towards doctors. Ultimately, doctors are furious because the government is shaking the medical profession to exploit the public resentment for its victory in the upcoming parliamentary election next week. However, regardless of the government's fault, once the collective resignation of resident and intern end, the question is whether they can return to the medical field. Doctors say they are shocked by patients blindly blaming doctors and are unsure if they can face patients again. Patients will surely treat these doctors with prejudices as resigned doctors. And so if the trust between patient and doctors has already been undermined like this, how can it be revived?
Well, that's a very long and very well articulated statement. I don't think I can give you a simple answer to that. I guess there's a fine line between where the idealism of being a physician and wanting to care for patients, and then the reality of either a political or a economic or the whole idea of the 100 hours plus working acts as a barrier for that idealism. And I'm sure the doctors like yourself studying to be a doctor in Korea has this idealism that can't be realized. I don't know if I have the answer to that. In the United States, that was an issue that residents would only now work 80 hours, an 80-hour work week, but it wasn't based on what you're discussing. It was based on safety. It was purely the safety issue. Before the safety issue, the issue of to err is human. You might have heard that statement that residents were overworked and overtired and not being able to provide optimal care because of their working 100 plus hours a week. Then from a safety standpoint, they changed it. I'm not really even sure that was 100% necessary, but it was, and it was done, and now it's accepted. Residents even want to work less than that now, and I understand the reasoning for that. But in your situation, it sounds like it's more of a political, economic system issue, system-wide issue. It might be something that you could write to me and we could talk about it offline, because I think it's just a very complicated issue right now to speak about. But I feel badly that the doctors that have this idealism, like yourself, that want to take care of patients, have the barrier. And as you said, if patients don't trust you, that trust is extremely important. You have to have a doctor-patient trust relationship in order to benefit the patient.
Okay, great. Someone else, please. Next. Yeah.
Hello. Thank you,
Hey.
Professor Berman. You can hear me. I'm from Nigeria. I'm a physician. I've been practicing for the past 2 decades, and I've once been a general practitioner. Once conducted my cesarean section, and so your experience resonates with me. And so, one question I want to have because of time is I could see the role artistic representation of bioethics have played in your ability to appreciate both the privilege and the presence of a physician. you started your medical practice when I was born. I told Anna I was born the day you started medical practice, and maybe I don't know why. It's so I am thinking since I began as a doctor, art using cinema, films, poetry, being able to reflect, think, using images like Socrates, I found that it has a profound effect in the ability of physicians or caregivers to identify with the patients. But in our practice here in Nigeria, in sub-Saharan Africa, we have little or nothing to do with the art. So does your ability to appreciate art, reflecting over art using images and using poetry, has it any impact in your ability to appreciate presence and privilege in patients? Thank you for your wonderful, very divine lecture. Thank you, Berman.
Thank you. Has it made me feel? It made me a better doctor. Let's put it that way. It has made me a better doctor to be able to humanize the illnesses of my patients, the travails of my patients. Don't get me wrong. I've taken care of many healthy patients and healthy mothers, healthy babies, and delivered happy times. It's just that when the prevalence of this is in my profession, I mean, there's some professions where death really isn't an issue or serious illness, but in my profession, even though it's rare, when it happens, it's very impactful. And I think all of us need that some type of mechanism to be able to draw back to our roots, so to speak, to that art of medicine. And I don't mean art in the sense of drawing and visual art, but just the whole concept of it coming from within us rather than from our skills, so to speak. Okay.
Yeah, just one more question about empathy and sympathy. And we felt from our medical training, from the exposures we've had, where unwittingly develop a detachment or consciously not to be attached. And so while we try not to show sympathy but empathy, we end up tilting towards the side of detachment. Because a great doctor is a doctor that doesn't attach, doesn't have emotions, or doesn't involve himself. So over the years, but when I started listening to teachings like this, I found out that our teaching is inadequate to be the doctor you're supposed to be. So how do we strike the balance between not being attached and showing enough empathy as a doctor, as you have shown over more than 50, 60 years or 70 years now?
So that is something that I struggled with, particularly when I talk to medical students. And for those of you who are medical students, that my belief is that detachment may be a mechanism for you to detach yourself, but I don't think it's the right approach to total caring for the patient. And the best thing I can do is refer you to a book, or at least a statement by a colleague of mine. He wrote a book. He was a maternal fetal medicine specialist. And it's the title of the book tells it all, that doctors cry too. Doctors cry too. That it's hard not to express your emotions when you're at the bedside of the patient that you've been trying to care for and who's dying, or whose baby has died, or whose young child has died in your arms. I mean, I'm talking about, and you mentioned you were a general practitioner. I'm talking about the situation that we're in daily, in the normal daily routine of caring for patients. In thinking about wartime, for example, and babies that are dying, I can't even fathom that. So I'm not really focused on that right now. But But to answer your question, the rewards for being a doctor, I believe, come from attachment and empathy and crying with your patients than being detached. I call it confrontation as opposed to avoidance. Let's put it that way. Rather than avoid the problem and put it away, getting more involved. Because I have learned that the more involved you get, it's hard because your emotions are involved, but you won't be disappointed in what you did, even if the patient dies. You know you've put it all to it. Now, that's ideal. There's an idealism there. In the real world, especially, and I don't know what it, in the United States right now, I believe we're in a medical crisis. And the crisis, we have all the money, right? We have all the innovation and everything, but doctors don't have the time or don't take the time anymore to spend with patients that I did 30 years ago. And a lot of it is these external forces, what I call extrinsic forces that are impacting the way they could empathize or they could get more involved. I don't know. I don't know the answers to it, but my personal belief is that involvement, attachment, crying with your patients, empathizing is a better approach. Let's put it that way. Yep, I have time, so don't rush on my accord. I'm sorry I didn't need more time. Who's next?
Yeah. Who's next? Let me see.
Yes.
Yeah,
Whoever-
it's Evelyn. Nigeria. She's a recurring student.
I'm
but
from
this is-
Zambia.
Oh, hi.
Oh, sorry, Zambia. I have too many Nigerians. Sorry. Yeah, go ahead.
Yes.
Sorry. Yeah. Sorry, forgive me.
Yeah, so I don't know if my hand was up, but then I was agreeing with the previous question that Ike was asking, where he was talking about the balance. So I was thinking that I think doctors or healthcare workers have been taught to detach, right, with the patients. So I also wanted to ask, like, where do we strike the balance? Because I feel that the approach that the doctor is teaching us today is divine. Like, it's beautiful, and I think it would be wonderful if this is something that all doctors, all healthcare workers knew. Okay. And the other question probably I would ask Dr. Berman is that how are you teach, apart from classes like this, like how are you sharing the wealth of knowledge that you have with other medical doctors? I think it would be very nice if this was incorporated in medical training, right? Like from the beginning, doctors know that patients are people that I should treat with kindness, with care, and not detach myself from them, And it's beautiful. I enjoyed the lecture. Thank you.
Well, thank you very much. I think speaking with medical students about this subject is one thing, but I think that having doctors, teach by doing and by, as I mentioned earlier, being mentors, being role models, having medical students involved in patient care with the doctors that I'm not the only doctor that feels this way. I know that. I'm just giving you, these are all personal vignettes that I'm giving you. My life as a physician, but I believe that there are many, many, many doctors that feel exactly the same way as I do and have done exactly the same thing in their own in their own way. And I think that having doctors in a medical school, medical center, that where students can watch the way they actually interact with patients when they come to their doctor's offices and see how they see daily how doctors that feel the way I feel interact with patients. Then I think that that's the way students can be, can learn through this role modeling. I would always invite students to come to patients' bedside, to come to funeral services with me. It's really amazing when you think, even when you think there's a complication that might have been caused or contributed by you as the doctor, if you still keep this attachment issue, attachment concept, and you go to the funeral service or go to the bedside of the patient whose family might even be angry, the more I believe, the more you do that, the better it becomes, because you're not giving up, you're not abandoning your patient at a bad time, and you're able to take that medical student or resident and show them this is what you believe is the best treatment. We spend a lot of time in training our students in the techniques of medicine, right? How to treat patients, how to operate on patients, how to deliver babies, how to do cesarean sections. But what about how to talk to patients? How to really do that? I mean, there's a lot written about that, but I think as you alluded to, how do you actually teach it? And I think the way to teach it is one-to-one. Let the medical students do that. But you're right. It is a dream and an ideal. But I often think that I was fortunate enough to spend the bulk of my time practicing at a time where I could do this. Time is always of an issue. But yes. Another question?
Sorry, I muted myself. I was coughing. Sorry. Yeah, I apologize. Yes, someone else, please. Hello?
Hello, Anna. I hope I'm not asking so many questions. Hello, Anna?
Yes.
I hope I'm not asking many questions because I want us to ask what does this question that I forgot to ask you. And I don't know whether you have answers to it. Yes, please, just this one last question. Yeah, some years ago, a senior colleague came to my department and was talking about the behavior of doctors in politics, behavior of doctors in other fields of human life that are seen to be unethical, are seen to be full of vice. Then he said, in his own department or specialty, ophthalmology, that he found that Hitler and Osama bin Laden had doctors who are ophthalmologists that helped them, that worked with them. And then since then, we have imagined, for example, in Nigeria, we have the Boko Haram. Some people that were kidnapped told us that while they were in the forest, there were physicians, health caregivers that were treating them when they get ill. Then recently, we see the Palestine or the Israel-Gaza war and Ukraine, Moscow. You find out that while we are looking at the evil of war, we have physicians also sustaining or helping the presidents, the leaders, the commanders in killing, and then also in taking care of their soldiers. My question is this: have we lost the art of medicine? And if we have, what can we do to restore from Hippocrates, from Hygeia? What can we do to bring back the art of medicine? If doctors will be in terrorist camps, in taking care of terrorist nations, terrorist president, and we all belong to world medical associations. We all sit to teach the young ones. But in kidnapping, we help the terrorists. So some of our younger colleagues, my students are asking, where is medicine? Have we lost the art? I'm happy to remember this question to ask you, Berman. Sorry if you don't have the answers.
Yeah, that's a very heavy statement, and I really don't want to get into the politics, to be honest with you. I really don't. I hear what you're saying, but I don't think it's appropriate right now. I can't do it. All right, one more question, and then I think we'll leave. Yes.
Someone else, please. Someone else? Yeah, I don't see anyone.
Okay.
Okay.
Well,
So
please don't
we-
hesitate to write to me. I'd
Yeah.
love to hear from you, etc. And thank you, Anna, again for this amazing course.